Good evening, everyone. My name's Michelle. I'm a senior consultant with the Alberta Medical Association. I'll be moderating this session this evening. Welcome to the webinar, Building Blocks to Successful Transitions of Care, and thank you all for joining. This webinar has been approved for up to 1.0 MAN-PRO and maintenance of certification Section 1 study credits. All physicians who registered online and are attending the session will receive a certificate of participation. We kindly request your patience while we work on a process to efficiently send these out to you. At the end of the session, an evaluation link will be available, and additionally, a follow-up email will be sent to all participants to help us inform the ongoing improvement of the supports the AMA is offering. For this session, participants' microphones and cameras will be disabled by default. Participants will be invited to come off of mute and enable their video to ask a question. The unmute button can be found by hovering your mouse over the video window in Zoom, or by pressing *6 if you're joining via telephone. A couple of notes as we all continue to adapt to our new technologies. Images may appear small on your screen, so if you're on a computer, you can click on the View option menu at the top of the screen and adjust your video. Or from your phone, pinch and expand the screen as you would any other picture or video. We invite you to use the chat function to comment or ask questions throughout the presentation. The chat box is located in the webinar controls. If you're on a Windows device, this is located at the bottom of the screen. If you're connecting through an iPad, this button may be located at the top of your screen. We have a team of expert chat monitors today, and we also encourage participants to engage with one another during the session. As mentioned, there is a scheduled discussion period where we'll be inviting you to come off of your mute by raising your hand. We will review the process at the end of the formal presentation. So the links of all the documents shared in the webinar will be sent to participants in a follow-up email after the session, in addition to an executive summary of key messages. Links to the documents shown during the session will be posted into the chat box for ease of reference. This webinar will not be covering technical billing related questions. We'll also conduct 2 polls during the Q&A. If you require technical support, please use the link currently posted in the chat. Please note, this webinar is being recorded. By participating, you understand and consent to the webinar being made publicly available via link on the AMA website for an undeterminate length of time. By participating in the chat and live Q&A, your name entered into the Zoom sign-in may be visible, and other participants during the webinar and in the recording. We'd like to recognize we are webcasting from and to many different parts of Alberta today. The province of Alberta is located on Treaty 6, Treaty 7, and Treaty 8 territory, and is a traditional meeting ground and home for many Indigenous peoples. The program has not received any financial or in-kind support. We'd like to welcome our 4 presenters, our physician moderator, and our chat moderators. Next slide. All speakers and moderators have provided disclosures as outlined here. Now I'd like to hand it over to Dr. Brad Baylor.
Thanks, Michelle. During our session this afternoon, evening, our presenters are going to share information covering the following topics: patient story, how gaps in care negatively impact patient outcomes; how CII and CPAR technology can help close the informational continuity gap in Alberta; practice changes recommended in the newly released H2H transitions guideline; an example of how information received through CII and CPAR has practically improved patient care; an example of how leveraging your team to implement practice changes can improve transitions; And we'll also share additional transitions, webinars, and resources that participants can tap into. Next slide. So these are the three main learning objectives, and at the end of the session, participants will hopefully be able to identify where gaps in continuity occur and how the home to hospital to home transitions guideline recommendations may help address those gaps, recognize how CII and CPAR supports continuity and transitions of care, and describe how primary care teams have improved patients' transitions and care using these principles already. Today, we're going to hear from four guest speakers: Dr. Joseph Ajetikin, a family physician in Whitecourt and the AMA North Zone physician champion; Dr. Heather Laborde, a family physician based in Calgary and the AMA provincial physician champion. We will also hear from Mona Delisle, AHS Acting Executive Director, Primary Healthcare, and Barb McCaffrey, who is the AMA lead for the CII CPAR initiative. First, we're going to hear from Dr. Ajetikin, who's going to tell us a little bit around what it was like looking after patients prior to his implementation of CII and CPAR. Joseph?
Thanks, Brad. You know what, I think I would like to start by saying that as physicians, we hate to see our patients fall through the cracks. And we all know that there are many potential cracks through which our patients can fall as they transition through our complex healthcare system. As primary care physicians, one of the things we pride ourselves in fact, one of the major thing that separates us from our specialist colleagues is the ability to follow our patients through the different phases of their illnesses due to the longitudinal relationship we have with them and their families. However, we can feel disempowered if we feel left out of the loop just because our patients are visiting other facilities for care and we are not able to provide important information that would contribute to their care. So this story I want to narrate is about a patient I saw about 2 years ago. That it's a middle-aged diabetic gentleman who developed a non-traumatic cervical cord compression. He actually presented to my clinic with progressive ataxia for several months. You know the way you have some patients that almost completely rely on you to make important healthcare decisions. He was almost getting used to the way he was walking. He wasn't keen to be investigated, but I encouraged him to visit a neurologist. Of course, MRI confirmed that he had a diagnosis of a cord compression due to spondylolisthesis, and surgery was recommended. About 6 months later, he was still quite reluctant to go for surgery, but I encouraged him and his family to go ahead. And this is the meat of the story. Not being on CII-CPAR at the time, he went for the surgery. I had no notification that he had gone. Post-op, he developed 2 heart attacks and had to be airlifted once. I was not informed he was in the hospital. Then shortly after that, he had stroke that put him on a wheelchair for the rest of his life. And no information came into my clinic. Furthermore, he was rehabilitated for months in the Glenrose Hospital and then discharged from the hospital again. I was not notified. About a year later, he came into my clinic on his wheelchair. He was severely depressed due, of course, to the multiple post-op complications he has suffered. I was shocked over the condition of my patient after not receiving any information on his journey in the same province, in the same healthcare system. Brad, I was not even aware that my patient had surgery after almost a year. You can imagine that. That was very frustrating.
Yeah, and I think most of our patients assume that we know exactly what happens to them anywhere they go in Alberta for care, and unfortunately, that's not the case as a general rule. And you can certainly see how, had you known what had happened through the course of his illness, and had there been good continuity of information coming back to you, we would have had an opportunity to support him differently at a much earlier stage. So this is a really good example of what happens when there's a break in informational continuity. I'm going to turn it over now to Barb, and as the lead of the CI and CPAR initiative, Barb's going to tell us a little bit about how the technology has evolved and how it may prevent future events like this.
Thanks, Brad. I'm going to start with some components of our eHealth system. And this is a very simple view of eHealth in Alberta. And let's start with Alberta NetCare. This is the provincial electronic health record that collects information. And historically, it's been mainly from AHS systems, but other data as well. AHS is implementing a common clinical information system, moving from 1,300 systems to one in 9 waves over the next 3 years, called ConnectCare. Information from AHS has long been supplied for viewing in Alberta NetCare, but we do have community EMRs outside of Alberta Health Services and NetCare. These are HealthQuest, MedAccess, Wolf, PS Suite, and Accuro. This is where primary providers and specialists do most of their documentation. Community EMRs have been a receiver of information through e-delivery in Alberta, and that's long been appreciated. But now we have community information integration, the CII Data Hub, which allows for 2-way data flow from the 5 conformed EMRs that make up the majority of our community in Alberta. CII has 2-way data flow as well with the Central Patient Attachment Registry. And now the system can know which primary provider has a confirmed and established care relationship with which patient. Importantly now, this allows for e-notifications so that that primary provider can be informed when one of their CPAR paneled patients has certain events within Alberta Health Services. This is also a significant advancement in capturing community information and making it available to other providers in Alberta NetCare, where we are creating an eHealth environment for integration and continuity. Information is also captured by the Healthcare Data Repository, where it's used for analytics and quality improvement. And next year, community EMRs will be able to push information with other NetCare information to the My Health Record patient portal, where Albertans may have access to it. Let's take a deeper look at what CII CPAR looks like. At the clinic level, there are 3 types of information that is shared: the confirmed panel, patient encounter data, and consult reports. What the clinic receives and returns are e-notifications when one of their CPAR paneled patients has an emergency department discharge, hospital admission, hospital discharge, or day surgery. They also receive reports from CPAR itself, panel conflict reports, and demographic mismatch reports. The most useful is when they're informed when a patient is deceased. At the same time, Alberta NetCare is being changed and enhanced. It now contains 2 new documents: Community Encounter Digest, which is a rolling 12-month snapshot of patient encounters in community clinics that are CII enabled across Alberta. This sits in NetCare and represents a physician visits and assessments. Secondly, consult reports that only used to sit with the specialist and the primary provider they faxed it back to now also sit in Alberta NetCare. And this year, 2 new things will be added. In June, the name of the CPAR primary provider will display in Alberta NetCare, and community providers will also have the ability to upload a patient summary. Let's look now at progress for CII CPAR in Alberta. This is the early January data. We have 730 family physicians engaged, of which 490 are fully live in the system. At the specialist level, we have 234 specialists, of which 147 are live. In total, nearly 1,000 physicians in Alberta are engaged with CII CPAR. And right now, we have 126 clinics that are fully live. Let's look at some implications into that participation. The yellow bars represent physicians submitting panels to the Central Patient Attachment Registry between March and December of 2020. In December, there are 391 panels of physicians in CPAR. That means there were over 300,000 Albertans registered in the database with a confirmed relationship to a primary provider. This means that should those Albertans have one of those AHS events, such as an emergency department discharge or hospital discharge or day surgery, that primary provider would be informed in their EMR. Next, let's look at the actual data. This shows actual e-notifications sent out between July and December 2020. The colors represent the distribution by zone. In December of 2020, within that month, over 10,000 e-notifications were sent out to physicians participating in CPAR as an opportunity for a smoother transition of care so that they could follow up, if appropriate, with those patients. In this calendar year, we should reach 1 million Albertans in CPAR. That's a lot of potential for transitions of care. Finally, as I said, those consult reports are also uploaded into the Central Patient Attachment Registry. And as a result of CII, over 82,000 now sit in net care as a result. As well, over 237,000 Albertans now have this new document sitting in their Alberta Net Care record called a Community Encounter Digest that collects information from visits that they've had across CII participating clinics in Alberta. These are having an impact on informing care for patients. Back to you, Brad.
Thanks, Barb. It's really good to see the technology piece of this finally come to fruition. It's actually been a long path to get this up and running, and it's something that I think we believe really strongly in, the ability to share what's happening in our clinics back with the rest of the healthcare system. But technology alone doesn't solve the issue of transitions in care. There's a lot of care gaps that we need to consider as well. So we are lucky to, in addition to the technology piece, have the new home to hospital to home transitions guideline that really targets giving us some practical practice level behavior change advice on teams that might be looking to improve transitions in care. And so I'm going to invite Mona, who's here today, to provide us some details about this piece of work and where we're at with it right now.
Thank you, Brad. Yes, the guideline is aimed at strengthening the connection between primary care and acute care. So today we started with a patient story of a patient falling through the cracks. And then we talked about how CAI CPAR can help improve the informational continuity to prevent this from happening. The H2H guideline is another support and major initiative that looks to help to prevent patients from falling through those cracks. The guideline is Alberta's first province-wide transitions guideline for adult patients that will help healthcare providers and teams in acute, primary, and community care operate as a singular entity with patients and their loved ones as equal partners. The guideline is aimed at strengthening the connection between providers to ensure standard processes and practices across the care setting, informational and management continuity, and create a shared understanding between senders and receivers of information in the system. In turn, this will improve patient outcomes, experience, and satisfaction. The patients need to know, the patient knows who is doing what and when to call for each of their issues. As well, there will be an increase in provider satisfaction. Providers feel that the system needs to support them to provide the best care they can for patients. And we'll hear a little bit later. We heard Dr. Ajetikin's story about what it feels like to work in a system that's not connected. So perhaps we're going to hear later about what it feels like when it is connected. So I'm getting a note that I'm choppy, so I'm going to turn my video off. I think my internet is having difficulty you with all the 145 participants we have on this exciting webinar. So the development of the guideline started in mid-2018. The Alberta Health Services Quality, Safety, Outcomes and Improvement Executive Committee and the Provincial Primary Care Network Committee asked for a province-wide transitions guideline, which would outline what ideal transitions would entail. The Primary Healthcare Integration Network led the co-design of this guideline in an effort to build on existing improvement initiatives across the province. What you see here is an illustration of the 6 elements that we've landed on within this guideline. And it's here to, again, assist providers and teams within Alberta. This guideline will present within it leading operational practices, change management tools and resources, and additional information from the following sections. Starting with the confirmation of the primary care provider, this will allow us to see who the patient is attached to. And as you can kind of put the dots together already, you've heard from Barb that if the patient is paneled, this is going to be much, much easier in the AHS side of the system to know who the patient's primary care provider is. Once we know that, the admit notification can occur, which, as the name suggests, notifies the patient's circle of care when patients are admitted to hospital. Following that, we have some transition planning, where primary care may actively assist with the transition planning process. Referral and access to community supports is collaboratively work with the hospital team and provide any relevant information needed to ensure appropriate clinical and non-clinical post-discharge community supports. They can be arranged. And a lot of the community supports we know patients may have questions about when they're getting set up, and they may rely on the primary care provider to support them with that. And of course, the primary care provider in the system needs to know what the plan is. The transition care plan then can be co-designed with the patients and the whole care team, and receiving a care plan before seeing the patient in follow-up really assists that care continuity to happen and the management continuity to happen. Follow-up to primary care, having received the transition plan and being involved actively in the plan, the follow-up visit is just a natural extension of that hospital visit. Components of the guideline aims to ensure standard processes and practices across the care setting so that effective transitions are consistently experienced throughout the province. As outlined on this screen, you can start to see how CPAR can directly support the guideline and vice versa. I think that you're going to hear a little bit later in the presentation about an experience of a very innovative fax program that I'm not trying to steal Heather's thunder, but she's going to say how awesome their fax program was. However, once they moved to CPAR, they were able to axe the fax and really get those automated notifications into their EMR so they could really, in a timely fashion, connect with their patients. So you can see through each of these elements how the technology can enable them. The overall implementation approach of the guideline is just beginning. So we're on, I said this morning to one of my team members, we're on month 1 of a 3-year journey. So we're just really getting out of the gate. And the guideline and the technology that's been designed that you've already heard about are only as good as their implementation strategies and actually getting this into practice. And we're proud to say that we have really strong endorsement from leadership at both the Alberta Health Services side and the Provincial PCN Committee. The guideline was a co-designed approach across organizations, and implementation needs to be the same as well. As patients transferring across our systems expect it to be seamless. So we're really excited that we continue to work together, not just in guideline development, but in implementation. So as we're taking our very first steps into the implementation space, we are in the process of developing some early plans and approaches and strategies on how we're going to implement this. And we've got some early planning happening in both the zones and at the provincial level. So you can see in that middle row, each of the zones are establishing a transitions and care committee to support the activities within their zone required for the transitions guideline to be implemented. At the bottom, you'll see the Primary Healthcare Integration Network, which is a partnership between Alberta Health Services and the AMA ACT team, where we can provide some resources and backbone supports and change management tools to the teams that are actively doing this work. And we're in the process of establishing an advisory group that can help us navigate this complex cross-system project across the province.
Thanks so much, Mona, for the overview of the guideline and a little bit of behind the scenes look into how the implementation of the guidelines occurring throughout the province. And although a lot of the work is really new, there's many primary care teams who have already began making practice changes and implementing some of these ideas to improve transitions of care in their own settings. And so we're going to circle back to Joseph now, who's going to tell us a bit of a different story around how his early participation in CIA and CPAR and populating information into NetCare through the Community Encounter Digest has really resulted in improved care coordination with acute care.
Thanks, Brad. So thankfully, my next story ends happily. Now that I'm live on CI CPAR, I receive notifications directly in my EMR, similar to lab results. When patients are admitted to hospital or discharged from the hospital, or even if they visit the emergency department or even have a day surgery. You see, I believe that primary care physicians are the quarterbacks for all their patients. And we do a lot of work for our patients in the community as they journey through our complex healthcare system. Personally, I've worked in Europe and now in North America, and I can confidently say that CII, CPAR, and e-notifications are, in my own opinion, the best things that have happened to primary care in Alberta, because they truly enable us to do the job we are trained and love to do. So this previously healthy young lady unfortunately ended up in the hospital with a hemorrhagic stroke from a leaking cerebral aneurysm. She required surgery, but while she was in ICU, the attending physician battled a high blood pressure trying to determine the cause, but she wasn't previously hypertensive. Thankfully, the physician was able to identify me as a primary care physician through the Community Encounter Digest on NetCare, which Barb talked about, and decided to contact me. For this lady, there was no way anyone could have known that she was an active crystal meth user. We know that crystal meth use increases the risk of poor cardiovascular outcome by more than 5% due to blood vessel constriction and spasm, causing dangerous spikes in blood pressure with eventual cardiovascular damage. Having this additional information for this patient allowed the acute care team to provide the patient with appropriate care treatment plan with me and transition her back to the community. This is the type of information exchange that is made possible through CI, CPAR, and NetCare. Now she's back in the community without any residual neurological deficits. In essence, we can say the CI, CPAR enables timely, appropriate information handover that supports patient safety, efficient and effective patient-centered care. Back to you, Brad.
Thanks, Joseph. And yeah, much better ending to that story than to the previous one. So I think Joseph has done an amazing example contrasting kind of before and after, and how this is really can be transformative at a practice level. I'd like to now hand it over to Heather. And, Heather has some great experience using her team and leveraging them to try and smooth transitions for patients in the Calgary setting. And she's going to tell us a little bit about her work prior to CI and CPAR and some of the changes that CI and CPAR brought about. So I'll hand it over to Heather.
Thanks, Brad. So in the midst of the pandemic, family physicians became especially concerned about their patients and not knowing where they were in the system. It was during this time that we realized more than ever that we needed timely notifications about where our patients were in hospital, so that way we could be best positioned to care for them. So that's why my clinic took the COVID pandemic as an opportunity to go live on CAI and CPAR. So CI and CPAR was a natural extension to the transition work that the Calgary Zone was already doing. Before CI and CPAR, the Calgary Zone had an excellent fax system, as Mona alluded to, which was a workaround process to get information out of the hospitals with respect to discharge notifications. So Calgary Zone PCNs, we pooled our money because we thought that this was such a valuable piece of information that family docs needed, and we hired discharge clerks to go into the hospital to get information out. However, we started with 2 discharge clerks. Eventually there was 4. And so obviously that wasn't going to handle the full volume of information. So we did have to prioritize where we were going to put those discharge clerks. So the data was really limited to patients who are being discharged from medical units. So great information to have, but still we weren't getting any discharge notifications out of the emergency department or any surgical discharges. As you can see, so this process, it was a pretty good workaround. We thought it was super fabulous and super sophisticated, but there's a lot of hands in this pot. So we have our discharge clerks in the hospital, which would compile the information. They would then send that out to my clinic. My clinic would then, I'd have a staff member, so a person who would be responsible for linking that electronic fax to the patient's chart before I finally saw it. And so this process took, I would say on average, if it was really working optimally, 48 to 72 hours. But if there were any gaps in the system at all, that could really stretch out, and that became really apparent during the pandemic when people were required to self-isolate for 14 days. That suddenly, you have those 2 key members within the system. If they're down and out, the whole process stops. And so what CI and CPAR did is it basically eliminated this entire workaround. So suddenly our notifications became automated. They became timely. I was getting faxes twice daily at 6 a.m. and 2 p.m. and no humans were involved. So, again, we really did take a lot of the error out of the system. So I was excited to find out that by signing up for CI and CPAR, not only would I get discharge notifications, but I would also get e-notifications, which we talk about so much, and that these e-notifications would get sent directly into my EMR, similarly as to how lab results are now received. This would help to make transition work, care in my clinic, which we are already doing. We are able to do it faster. So the biggest win for me out of the e-notification pot is really the emergency department discharges and the surgical discharges. Each of these notifications is an opportunity to check in with the patient and to make sure that they've got a clear understanding of their care path. Each notification is an opportunity to get information from multiple services within the system. So again, now I have access to emergency records, day surgery, admit, and discharge. So for example, I've had patients go off their care path and then they kind of crash and burn in the emergency department. However, thanks to e-notifications, I now know when those patients are discharged from the emergency department, and I can start to build the supports to get them back on track. I'm finding that this doesn't take a whole lot of time. Typically, it takes me less than a 10-minute conversation with the patient to ensure that any follow-ups they need have been arranged seamlessly, that they understand the importance of any medications that were prescribed and they actually fill those medications, that they know that the patient agrees with the care path from the hospital, that I support it, and that they have the supports in need. So through the transitions and care improvements my team made at my clinic, we were able to see significant and measurable improvements in patient safety, patient outcomes, and patient and provider satisfaction. The readmission risk screening process, we used the LACE risk stratification at our clinic. We implemented and medication reconciliation process has helped to improve our clinic efficiency, and it's allowed for more time to focus on providing clinical care. I find that my patients want to be reassured about their care plan from me as their trusted source. Patients want to know that their family doctor supports the plan provided in the emergency department. For example, I had a patient of mine who was discharged and was experiencing the post-surgical discharge and was having some pain, and it was just before the long weekend. So I received a notification the same day that the patient was discharged. And this allowed me to have a quick phone call with the patient, quickly check in. How are you doing? How's your pain? Are you able to move? Do you have questions? And then I was also able to provide a backup plan over the long weekend. So that way they knew that if something were to go untoward, here's how they could best access care. I find that even when I'm giving patients the same information that they received in the hospital, having that conversation the next day really does help to solidify the information. Joseph alluded to that longitudinal relationship that we have with family doctors. And, we're the person that they trust most. And, when you're in the emergency department or when you're in the hospital, those are really busy environments. You don't have a relationship with the providers there. There's a lot of information coming at you quite fast. And so having that follow-up conversation where we're able to go through it with time, one-on-one, really does help to make sure that they know their care path and they know where to reach out to if they feel like they're struggling. So we measured a couple of key indicators and at our clinic, and we are super proud of this data. So we tracked through this project that we were able to reduce 30-day readmission rates by 67%. And for those of you who don't know that, that's patients who are readmitted to hospital for the same condition within 30 days. We are also able to reduce our seven-day ED visit return rate by 67%. And we also were able to reduce our wait times for post-discharge follow-up assessments by 12 days. And this again was for our high-risk groups. We've also seen improvements in patient satisfaction from the process changes we've made. And patients feel like we're being very proactive about the care when we reach out to them post-discharge. They often think that I'm going above and beyond the call of duty. And, I really feel now I finally am able to properly do my job and to quarterback their care. I too am much more satisfied now that I've got this technology to fulfill this duty. I find that being able to follow up with patients through e-notifications helps me to spend more time with my patients and feel more connected to them. This also helps me feel like I can better direct patient care because the information is coming back to me. I can now get the information, I can validate it, I can reach out to my patients, and I can make sure that they're on the right path. As a family doctor, those relationships are a lot of the reasons why we're in family medicine. And so every opportunity, including these little micro encounters, just adds to this relationship and it adds to the satisfaction of the work. As well, being prepared with the discharge summaries and notifications allows my clinic to run much smoothly. So I'm now organized for the patient visit. I can reach out to team members that I may want to task work to, such as my pharmacist to do a medication reconciliation. I'm organized for that visit. And so what that means is that, no longer am I, running out to Netcare to pull information. I've already had it, I've seen it, and I'm ready to engage with the patient as soon as they walk through the door. So this has allowed the clinic to run much smoothly, and it's allowed me to get out on time, which I know my family really, really appreciates.
Thanks so much, Heather. Your clinic has prioritized transition since long before CI and CPAR, and you guys have obviously done some fantastic work to connect the dots and ensure patients have smooth transitions, and the data is very impressive in terms of the impact that can have. And so I'd like to thank all our presenters for sharing their stories. And at this point, I'm going to pass it back to Michelle, and we're going to move into the question and answer portion of the webinar. So with that, I'll hand it back to you, Michelle.
Awesome, thanks. And thank you so much for all the great stories that were shared today and experiences. So the next couple pieces is during this Q&A, we're going to be asking participants to use the virtual raise hand feature, which is located in the participant menu at the bottom center of your screen. To use this feature, first open the participants window and then click the raise button at the bottom of the screen. But if you're on your iPhone, this will be in the more options menu. So I will then select participants who have raised their virtual hands, ask them to come off mute and ask their questions to our panel of speakers. If you can identify if there's a specific to primary or specialty care, please state that in your question. And after you have asked your question, remember to lower your virtual hand. We're also going to be launching 2 polls during the Q&A session, which will appear in your pop-up window on your device. So if you're invited to respond to those poll questions while we are active in discussion. So please note, on your Windows device, you may need to scroll down through the poll options to see the submit button. And if you're on an Apple device, you may need to select the next button to see a second question and then click the submit button. Are you guys ready for a poll? Antonia, if you don't mind launching it, please. So please, the first question is, filling which current gap in care transitions will make the most impact for your patients? So choose 2 of those choices, your top 2, and let's see what everybody else has to say. Sue, while we're waiting, I'm gonna see if there's any hands that have any hands that have been raised for questions.
So I'm not seeing any hands being raised at the moment, but I do have a question. So if I were a primary care physician, I would be thinking about how AHS acute care is readying themselves to adopt the home to hospital to home guideline. And I'm wondering if Mona might be able to respond to that.
Thank you, Sue. That's a great question. So as I mentioned earlier in the presentation, we've had senior executive leadership within Alberta Health Services endorse this guideline and ask us to begin implementation over a 3-year period. The Primary Healthcare Integration Network is supporting some of that implementation planning. But the other, I feel like in a way, a number of things are aligning quite well in our province. And so we've got CII aligning, the guideline aligning all at the same time, Connect Care being rolled out over this period of time, but also the recommendations from the AHS review, which those recommendations emerged out of the Ernst & Young review, which identified some really clear clinical recommendations to improve outcomes for patients in our system. And the implementation team for those recommendations have endorsed the home to hospital to home guideline as a foundational piece of work that can improve that hospital stay, the length of admission, and reducing the readmission rates, both of those indicators that Heather talked about earlier. So we're in the process right now of doing site engagement with the top 16 largest hospitals in Alberta and working with them to start to look at how they can begin their implementation planning around not just the home to hospital to home guideline, but there's a number of other initiatives also identified in partnership with that to improve the experience and the flow for acute care for patients and providers. So the work is starting, and we'll have more details around the implementation of that to share in a couple of months. Like many of you, COVID has kind of put a little course correction in some of our plans, and so our engagement was delayed, but there's huge endorsement from this work at the senior leadership within our organization.
Thanks, Mona. We're going to just reveal the poll results, and then Sierra, you're up next for the next question. So we've got primary care providers being notified when patients are discharged was the number 1. And the number 2 was comprehensive discharge plan to be included, transitions care plan. So awesome. Thanks for the responses. That's good news. Sierra, can we ask you for your question?
Sure. Thanks, Michelle. So I am very passionate about the home to hospital, home transport, as some of you may know, but my question is actually specifically for Heather. So when you were fully when you fully got onto CPAR and you started to manage those admit notifications, when they started to roll in, how did you manage them? Was it overwhelming? Was it just, I think some people have this perception it might be like hundreds a day. So how do you manage that? And so I've been very interested to speak with some physicians as they go on to CISC-PAR. So was it overwhelming, and how did you manage it?
Great, thanks for the question. So absolutely, it was not overwhelming. The statistic that Barb will probably quote you is that the average e-notifications that a doctor will receive per week is 14. And I'm at my clinic 3 days a week, and I get about 10 on average. So I think that that stat holds true. And again, what I find is that they come in just as I'm reviewing things. So I find it's kind of already embedded in my workflow. And what I've been doing is I've been reaching out, if a patient's being roomed or if I've got a little bit of downtime, that's when I'll use the time to act on them. And I'm finding that typically, it's usually less than a 10-minute conversation, and often it's a 2 or 3 minute conversation. So it certainly isn't taking any time. And what I am finding though is that time investment up front pays in the back end, as far as that I'm much more organized within the clinic, and that things just run smoother. Like I feel like there's less disasters that I'm having to kind of clean up. And the other, benefit that, we don't sort of talk about is that, now these phone calls are compensated. So, I use those billing codes appropriately. So, if it's less than 10 minutes, I bill an 0301 AD. And if it's more than 10 minutes, I bill an 0303 CV. Does that answer your question?
It sure does. And actually, you rolled into my second question there. It's going to be around compensation for your time to do these activities, because I think that is another burning question that family physicians might have. So thank you for doing that. And I will certainly be reaching out your way, Heather, because I think your story is really fabulous and it's one that we want to be sharing. So thanks.
Awesome. I think we'll take this opportunity to launch our second poll, and feel free to put any questions you might have in the chat box while we answer this poll. What additional information do you need to help improve transitions in care? And again, pick your top 2 choices that you think are required. And while we're waiting, is there anybody that has a question that they'd like to ask any one of our panelists or our group in general?
Michelle, while people are considering that, I was just wondering if we maybe could have Joseph come off mute and describe how he's utilizing his team to action some of those e-notifications that are coming through. And also, of course, with a vulnerable population, you might expect to receive more notifications, and Joseph's panel is definitely in that realm. So Joseph, could you maybe come off mute and talk about that?
Yeah, you're right. So my panel size is about 1,600. And I guess on the average, I've actually looked at the numbers, about 4 to 6 per day, maybe slightly more after a weekend, but generally about 4 patients per day in terms of notification. We tried a few, we did a few PDSs around how best to deal with it. Initially, I tried with my assistant, and it didn't work so much because she doesn't have a medical background and all that. And it's important when you get a notification to look at the background history of the patient, why the patient was perhaps in the hospital, and how best to deal with it. Then we used our chronic disease nurse in the clinic. Again, I felt there was a little gap between when the notification comes in and when we act or react appropriately. So I decided to do it myself, and it's quite easy because it comes in quick. It comes in just the same way you receive results, and it's so interesting because we interact with it with notifications in different ways. I work in a rural community, which is transient community. I have patients that are seen. I live in Whitecourt, and it's about 2 hours up Edmonton. But I have patients, for example, that get notifications from Medicine Hat, from Calgary, and we just wonder what's happening. So sometimes an opportunity to reach out to the patient to find out if they have moved out of town, and sometimes an opportunity to clean up your panel. Sometimes you get a notification, you see the same notification was sent to another physician. It's an opportunity to clarify with the other clinic and the patient who the patient actually belongs to. So it's actually very useful at multiple levels, how you interact with those notifications. We have used it in addition to some other processes in place to clean up our panel in our practice of about 5 doctors. So it's really working quite well for us that way. And I have a question, if you don't mind, actually.
Go ahead. Please.
Yeah, I was just thinking now that we're having an increased uptake amongst physicians, and more and more patients will have their visits visible on a community encounter digest on Netcare. Is there any plan to train some of the hospital specialists and ED physicians on how to interact with those information to confirm attachments in the hospital?
Mona, might you have some
Absolutely, Dr. Jedikin. We're looking at all of the different, I like to kind of talk about this around cause and effect, or where there's an action, there's a reaction. So we've not done a lot of awareness building around this in acute care or ED yet. I know there are some of my acute care partners are on the call from other SCNs, and we'll be reaching out to them to get the word out. We really wanted to invite some of our acute care partners to this as well, to start to engage them in this, but absolutely we'll be taking it back to say, what is the communications plan around some of these things? How do we engage our acute care partners? But more importantly, how do we co-design with primary care and our acute care physicians together? So lots to come. Great question. Thank you very much.
Thank you. We have a couple other questions, guests that have some questions. So I'm going to refer the question to Carla. Carla, would you mind coming off mute and sharing your question?
Absolutely. Thank you. Great presentation. I really enjoyed it. My question is around calling people for e-notification that they've been discharged from hospital, and specifically if there's no discharge summary available yet. And sometimes I've seen people in clinic where they've been discharged the day before, and I really don't know what happened to them, and I don't have a discharge summary, and they're asking me questions that I don't know the answers to. So I guess my question is, how often are you finding this happening, and is there anything that you can help to fill that gap when that happens?
Barb, might you want to take, or one of our...
I think that sounds like an AHS problem. What I will say, we hear you. That's one of the measures that we've identified is what's the time it's taking from when a patient gets discharged for that discharge summary to get on to Netcare. We recognize that it's variable across the system. One of the good things that's coming out of Netcare, so I'm assuming you're not on an Edmonton site, but we've recently identified that those summaries are going to go out onto Netcare, even if they haven't yet been approved by the physician. So that's one of the processes is you dictate, it gets transcribed, it comes back, and then it has to get approved, and then it goes on Netcare, and that process can take quite a bit of time. So the Netcare team said, look, we are able to release discharge summaries to Netcare that are not fully approved, but there will be a disclaimer on that, because it was felt like it's better for primary care and other care providers in the system to have some information than no information. And so that change is coming, but we recognize that, and we're starting to do some quality improvement work around that, because it is a key element. And you're going to get the notifications, you're going to see the patient, but there's still a gap in the informational continuity.
Awesome. Thank you, Mona. We have one more question. Cornelius, would you like to ask your question? You'll have to come off mute though, please.
Thank you for very much. I appreciate it, y'all. It was a good presentation. Just to quickly to ask, we from our PCN had a board meeting 2 nights ago, And we were also going through the home to hospital to home, sort of like guidelines. And we had like this 13-point, guideline step that was there. And one of the questions was raised by one of the board members was that, and basically the point was down to this, that the primary care provider or team will actually book and arrange any outstanding tests or procedures needed to be done post-discharge. And immediately the question was raised, well, isn't this now creating a sort of like a possibility for a problem of workload dumping to the primary care provider? So and I said I would raise it when we're having this session tonight. How will that be prevented, that the people in the acute care setting do not sort of like try and dump down the responsibility to the primary care provider to actually arrange any necessary investigations or further follow-ups, besides what I as a primary care provider would do if I get all the information that was being done by the investigations as it comes through.
Thanks, Cornelius. I don't think that's how it was intended, but we're very fortunate to have Sarah on the call. So Sarah Cunningham, sorry, Sarah, I hope you're on. She's one of our scientists that was very much involved in the development of the content. So Sarah, do you mind if I actually hand that question to you?
Yeah. So Cornelius, if I understand kind of the way you're propositioning this, I want to go back to your statement around if the discharge summary comes and I get all the information I need as a primary care provider. I think it's contingent on that statement that likely if you're having like a shared care plan between acute and primary care, the assumption is that acute and hospital team will do all the things that they need to set you guys up well within primary care. I appreciate how you raise it's a risk factor in that acute could start pushing this workload onto you. So we're going to take that back and we'll look at some of the wording within the guideline and how that's positioned. But I think the ideal state is that both teams are communicating really well and that the discharge summary or a synopsis comes across. And so both teams would take on equal parts. And if there's anything that needs to be done within primary care that was not followed up with hospital team, it would be things that would be within your scope of practice and within the things that you would normally do for following up your patients when they come out of hospital.
And I would just add, Cornelius, that the transition guideline, has not changed the responsibility, that CPSA gives to docs to follow through on their own work and appropriate investigations. And so, it's just converting the old paper way we used to get that information from acute care, or sometimes not from acute care, into a more reliable process. So the expectation is still that specialty follow-up investigations, specialty follow-up tests that are appropriately monitored and done by the provider who looked after a patient in hospital are still done by that provider. But there, of course, are things that are appropriate for us to follow up that may be way down the line, or maybe better handled in the primary care setting. And I think the statement is, that where appropriate statement is meant to say, that this is a shared care plan and that the work that goes back to primary care is appropriate for them to follow up, not that they take on added responsibility.
Awesome. Thank you. We're going to reveal the outcome of poll number 2. And the most popular answer was information on what improvement acute care will be making to support transitions. So thank you for your questions. We've just got a couple final wrap-up slides. And if you have any questions going forward, feel free to email us. Next slide. So there is a number of resources that are available. And you can find some recorded webinars on the guideline, on transitions, measures, and orientation. And future resources are being developed for change management. as well, and you can find some information on the website. In closing, I'd like to take this moment to extend a big thank you to for your participation in this webinar and to all the presenters, moderators, chat moderators, and team members. Thank you so much. And we encourage you to please complete the webinar evaluation by directly scanning the QR code with your smartphone, clicking on the link, which has been pasted into the chat box, or by following the link provided in the post-session email. Thank you so much, everybody. Stay safe and healthy, and have a lovely evening.